to BW Healthcare World. In our series of conversations related to the quality and patient safety in India, this episode is on how to build a culture of safety and quality in hospitals. To have this discussion, I have with me Dr. Lallu Joseph, who is the Associate General Superintendent, Quality Manager and Accreditation Coordinator of the Christian Medical College, Vellore, India, which is the largest hospital in India to be accredited by NABH. She's been a passionate teacher, a trainer. She's involved in training quality implementation across the country through NABH, CAHO, AHPI, and is also the faculty for many hospital administration programs. Being a principal assessor at NABH and the Secretary General of Consortium of Accredited Healthcare Organizations in India, she's absolutely passionate speaking about quality and patient safety. Welcome, Dr. Lallu Joseph.
Thank you. Thank you so much, Harbinder, for having me today. Thank you so much for the introduction.
And Ms. Joseph, can you define what a culture of safety and quality means in the context of healthcare, and why is it so important for hospitals to prioritize this?
Yeah, it's a very good question. I think the first question, the prelude to this entire session. So let me give you a small history, a background about how hazardous hospitals can be. It's a very, very hazardous industry, if I may so-called, call the healthcare professionals, the hospitals as an industry. It's extremely hazardous for a patient to be admitted in a hospital. Why am I saying that? Because 1 in 10 patients who get admitted in a hospital, as per the documented figures, get harmed. So these are not deliberate harms, potentially avoidable harm. So, we get very scared when we get into the aircraft. When there's a small turbulence, we think that the aircraft is going to fall and we are going to lose our lives. But airlines, we all know, is one of the safest industry. Same is the case with the nuclear power plants. But when you come into a hospital as a patient, you think this is a safe place. But it is not so. It is like tying yourself to a rope and jumping from top of a cliff. It's like bungee jumping. It's equivalent to that. So the airlines and nuclear facility, they are under the ultra-safe industry category. But healthcare falls under the hazardous industry category. That's because there are too many people working in healthcare, taking care of one patient. It could be doctors, nurses, technologists, other people. And if all of them do not synchronize, talk to each other, communicate about that patient, it may end up in errors. And that's exactly what the problem is. So healthcare, in my opinion, is really, really hazardous. And we see that day in and out. So the most important thing that all of us are trying to do is to transform this industry into a high reliability industry. Airlines, when we talk about it, it's highly reliable, high reliability. Whereas healthcare, the problem is so that it's so labor intensive. It is not standardized protocols. Every patient is different. Every situation is different, that you cannot actually point A, B, C, D. It has to be customized to the patient condition. And therefore, protocols and standardization becomes really next to impossible. And human factors come into the play. So that's why creating a culture in the organization is so crucial. So when one person talks about safety, it is the attitude of that person. When everybody in the organization starts talking about safety, then it becomes a culture. So, 10, 15 people talk about it. Okay, the culture is just developing. But when everyone talks about safety or quality in the organization, they imbibe that, they understand the value and the benefits of that, then we know that there is a culture of safety in that organization. It's a long journey. We are nowhere there. So that's why, the whole awareness today is to create that culture of safety in the organization. And we all know in our country, the culture of safety doesn't exist at all. In a bike, you will see 4 people seated without helmet. And that's the setup we are brought up in. And the same workforce that is working in a hospital probably comes to a hospital like that as pillion drivers with 2 or 3 without the helmet. And when they get into the hospital, we expect them to have that culture of safety. So the transformation has to start actually at the home front, schooling, but at least when they are with us, it's so important because other people's lives are in our hands. So we really have a challenge with creating this culture of safety in our healthcare organizations. So I hope I've answered to your question.
Absolutely. And, Ms. Joseph, I've spoken to a lot of healthcare professionals, and whenever I'm speaking to business leaders in the healthcare industry, and specifically hospitals, each one says that, we've got the patient at the center of our conversation. We are a patient-centric service. And obviously, quality and patient safety is at the center of the focus. But we don't see that actually translate into action when you go to many hospitals. What are some of the key challenges that these hospitals typically face when trying to establish and maintain, the culture of safety? Because, this is a top-down approach.
Exactly.
Right? So what are the challenges that we are facing because of which it is not transforming into reality?
Yeah, I think you gave the answer. It is a top-down approach. And I think the crux of this entire thing to build a culture of safety rests with the leaders in the organization. And if the leadership is convinced, and if they know that's the way forward, they have an open door policy, and they don't reprimand people for the errors that are committed, because anybody can commit errors. And if the incident reporting culture in an organization is very strong, that people get into understanding why certain incidents are happening, finding out the root causes or cause of that, trying to do corrective preventive measures. And if the leader is there to support this entire thing, then the culture of safety will certainly come into that organization. But most often, I think the media also is to be blamed in a lot of ways. Certain small things are blown out of proportion. We have to realize that mistakes will happen. Preventable harm is something that we have to focus on. But despite all that, there could be possibilities of problems happening. But we have to take it with the right approach to understand why these things are happening, give people the time and efforts to go into that, try and correct the system. But before that, if everybody just blows out of control and starts shouting about it, and that poor person who's committed that small mistake, or rather for a patient, it's probably a very large mistake, but that person goes into the shell, and then that person becomes what is known as a second victim. So our biggest challenge today is actually hand-holding these second victims, who are the doctors and nurses who have committed these small mistakes. And it's actually 2-3 people coming together. It may not be that one individual. It could be 2-3 people, because it is all system-driven, process-driven problems that are in our healthcare setting. If we don't support these second victims, we are going to lose them. They don't have that confidence to perform any procedure after that. But if the leader is not supporting, and if the leader is also singing the song in the other direction, then the culture in the organization will never get established. So the role of the leadership is extremely crucial. And that's exactly why from CAHO, we are trying to get the leaders involved in this, trying to tell them that, these things are to be handled with a lot of care. You have to have an open door policy. You have to start setting the tone in your organization. You have to walk the talk. You have to be a leader inclined to safety and be part of the team in understanding the problems and sorting them out. So the simple answer and the only answer is the leadership commitment.
Fantastic. But, Ms. Joseph, how does a leader define what is a mistake which is acceptable, something that we can learn from, move ahead, and something which is an outcome of negligence? And negligence could be because you've not paid attention to the safety aspect.
Yeah. So as healthcare leaders, when we go through the incident reporting, when we exactly understand, we sit through the sentinel event analysis, the adverse event analysis all the time. So what happens is, as you go through the analysis of this, when you do an in-depth understanding, when you really understand what exactly has gone wrong, 99% I would say is system driven. It's not one individual driven. So this best example could be a retained instrument in a patient's abdomen. Let's take that example. Nobody deliberately tries to put that instrument there and do the suturing, correct? So it is actually, if you look at it, there is the role of the scrub nurse who actually has to count every gauze piece, every small instrument that has gone in. And there is an assisting surgeon who has to actually look into the counting, try and understand it. And everybody actually takes their hands off the surgical procedure once this counting process starts. Sometimes, there could be a deterrent of a phone call coming into the theater. Somebody would have gone to pick up that phone call and that small number would have got missed. When we go through the analysis, most often we see, as I told you, 99% of time, it is these kind of small miss or slips in the steps that ought to be followed that cause these major problems. Of course, if there are deliberate issues and if there are people committing the same mistakes again and again, not the first time, the second time the same type of mistake happens, certainly there is a problem. So we will need to look into it. But trying to jump upon them in the first episode, trying to, witch hunt, trying to identify who that person, and most often it is the most vulnerable who gets caught in this. So I think it's extremely critical to draw the balance. It's a very fine balance. So you have to be very, very cautious, careful. And that's why the culture of safety, making everybody aware, understand, and not to pick up phone calls and make sure, you are aligned to the process, that will create that edge to say that errors will not happen.
Absolutely. I think, what I hear is that it is a very human-centric approach that we need to take. But while we take a human-centric approach, we need to build processes and systems to ensure that we do not make the errors which could have been avoided, right? And Ms. Joseph, what are the essential elements or strategies for building and fostering a culture of safety and quality in a hospital?
Yeah. So leadership commitment is something I mentioned earlier. So the safety training has to start from the very beginning. In organizations, particularly medical colleges, we teach anatomy, physiology, biochemistry, and it just goes on and on. But the component of patient safety only comes into the picture when they come in as CRRI, as interns, when they actually come into the clinical practice. So the training has to start for the medical professionals from medical college, nursing college days. And it's so crucial to tell them the kind of data that is involved, what they are going to be working with, and the involvement of patients in actually being stewards of patient safety. I'll talk about that, a little later. But the most important component is to catch them young, these professionals, and try and teach them, inculcate the culture there when they are in the academic institutions with us. So the academic institutions have a major role. That's one. The second thing is when they come into an organization, they have to understand the culture of that organization, the protocols, the processes that are involved. And standardization is very crucial. So what happens when a senior surgeon has a big ego? He's got his own standard protocols. Unit 1 will carry one protocol, 2 will carry another protocol, 3 will have another protocol. So those are things that are deterrents, because imagine a postgraduate who's trained in Unit 1 and the next day he moves to Unit 2, he's going to make a mistake because the protocol is different. So that's why the principles of quality management, the standardization of protocols are so crucial, that everybody has a standard protocol to follow and it's not dependent on units or individuals or professors. So that's something that we have to really work on. And I think accreditation has played a major role in getting the standardization of protocols in place. So that's point number 2. The third thing is, of course, really incorporating the culture of reporting incidents, the I for safety and quality. So if you potentially think that something could end up in a problem, you have to start reporting. You should have that sense that, okay, this may potentially become a problem. So for which you should not be scared. And it could even be anonymous reporting. You don't need to expect everybody to put their name and designation and report. So an open door policy towards incident reporting is very, very crucial. So with organizations, when they have this open door policy to reporting of incidents or near misses or anything which is a potential hazard, if they go in depth into that, it will be very, very important. And I think that will create the safety culture. It will make it happen. But I feel today, it's very crucial to engage with the patients. Because as a patient, if the patient is aware of the safety measures the healthcare professionals need to take, then they will become like the big boss watching over the healthcare professionals. Like I went in for a surgery of my right eye. The only thing that I looked at was the surgical site marking, because I was so concerned that my left eye should not be operated. And I know that surgical site marking, if it is in the right eye, that eye will be operated upon. So I was an engaged patient. I asked the most relevant questions and I understood the importance. And if the patients know that the healthcare professionals will have to wash their hands before they touch them, because it's a potential infection that they're going to be giving to the patients. And if they ask the right question, have you washed your hands, doctor? Have you used the sterilium? See, that's actually a reminder for the healthcare professionals. So the engagement with the patients, we call it today we have a beautiful tool called as the patient reported experience measures. As quality professionals, we use them to understand whether the patients were engaged. So if we get into that culture of engaging with our patients, telling them, these are the steps that need to be followed by your healthcare professionals, they will actually guide you and ask the pertinent question. So I think that's a very good strategy to build the culture of safety in your organization.
And Ms. Joseph, in your experience, what have you observed that are the common misconceptions and barriers because of which healthcare professionals may be restraining from embracing the culture of safety and quality? What stops them? What myths or misconceptions would they be dealing with?
I think the first thing is the fear. The fear of I feel, they get really scared to report anything. There's a lot of bureaucracy also, the junior level, and then it goes to the senior and then the head of the department. So it's like a very regimental organization. Particularly the nursing is so regimental that, if the head nurse says something, all of them will follow. They have to be regimental because otherwise mistakes can happen. So they get scared also in the process. So fear, I would say, is a major deterrent. And the other aspects, of course, the attrition levels may not be so in large organizations, very well-established organizations, but most hospitals have very high attrition, particularly at the nursing level and the junior doctors level. So what happens? You're constantly training and training and training, and within 2 months, 3 months, people leave you and go. So to get them to understand the culture, understand the organization, understand the protocols and processes, it takes time. So attrition also is playing a very important role, I feel, or a deterrent in most organizations when they really try to establish that culture of safety and quality.
You know what, Ms. Joseph, while you were talking, something, I'm getting a little confused. And to be honest, if the leader is in acceptance of these mistakes and allows them an opportunity that, it's okay, learn from it, move ahead, versus being someone who's got the image of, I'm not going to accept any of these errors, both have different implications. He could be seen as someone who's very weak. It's okay to make mistake, you can get away with it, versus somebody who's strong enough, ensuring that people need to be careful. How does a leader balance between these two to ensure, because, culture will happen in both ways, but both could be very different outcomes.
Yeah, I think you nailed it. So I think it's the mediocrity that is needed. You just cannot say, okay, come what, you do what you want, I will stand by you. That's exactly not what I mean. The leader, when we say, has to be part of this entire process to create the culture. It's not that he or she has to accept whatever mistakes everybody makes. But what is needed is to go in depth to understand the problems that are there, not to just jump and come to conclusions and start shouting and making sure everybody is thrown out, giving them a memo. That's exactly. So it's the scientific way of managing. And as I told you, most often it is not that individual. That individual has so many processes linked to that particular step. So there may be 10 or 15 people involved in this whole thing. So it is not that individual to be corrected. So you have to correct your process and your system. So the leader first has to understand, rather than just pinpointing and saying that person, he has to understand the process. That's what I mean. But certainly, it's important to be a very firm leader too. That thing that I am not going to accept mistakes has to come out also. But when mistakes happen, you don't jump at it. You have to be supportive as well. So it's a fine balance the leader has to play. So the leader cannot be smiling or growling all the time. So it has to be a balance which is needed. But he has to give the confidence to his employees that his doors are open and they can come and talk to him, discuss with him the problems, and he is open, available for them. He has to walk the talk. He has to get into the place, try and understand and be with them, even before the mistakes happen. So it's a very open door policy, which is what is crucial in a healthcare organization. And they cannot be sitting in their ivory towers and listening to others, their subordinates, and coming to conclusions.
I think it's more like trying to figure out that what the person did, was it the right thing to do at that point in time? Because in hindsight, it could appear like, why did you do this? But at that particular point in time, that may have been the right thing to do. So I think, that could be one of the ways in looking at it. But when you're looking at a hospital, it is not just the doctor, it is not just the nurse. There are a lot of people in support units which are working there. Your housekeeping, your attendants, people working at the reception, people who are transporting the patient from, say, a operatory to, to the room, etc. How does this culture of safety trickle down to those people who are not directly, involved in the delivery of healthcare per se?
Yeah. So if you look at the various groups of people who are involved, all of them have very, very specific roles. So let's say if it's a patient transporter, he needs to fetch a patient from ward to ICU or from theater to. So there are specific requirements of safety which needs to be taught to them. For example, if it's a wheelchair, certainly they have to be having the seat belt. If it is a stretcher, the side rails will have to be on. And before touching the patient, he has to use a sterilium and he needs to know that he could pass on the infection to that patient. And he has to wear a mask if he has a cold or a cough, or if the other patient has some infectious disease, then he has to protect himself also. So the basic concepts of safety that he needs to look into has to be taught to him. He need not be taught about surgical site marking and surgical safety and things like that. So it is very specific to the roles that individuals have taken up. So in hospitals, when they come in for the job, there is a very clear training schedule that is prepared for them. And they are taught as to what they should be doing, the various risks associated to them, to the patients, and they are taught in such a way that they know the safe practices. Often what happens, they don't take it very seriously also. So that's why the continuous training, reiteration is very, very crucial for them. And as I told you, accreditation has been a great game changer in Indian healthcare system, particularly NABH accreditation, because it is from the doorman to the chairman that everybody is interviewed, audited, assessed. The protocols are looked into, the safety incidents are looked into. So everybody is tuned to that, particularly accredited organizations. So the roles defining the responsibilities become very, very crucial. So you cannot be moving an attendant suddenly as a housekeeping staff. If you're going to be doing that multitasking, you have to train him into that. Otherwise, you all know the incident that happened in Mumbai, in Artrak. What happened? A technician who joined that particular day was asked to take, there was a very sick patient who was coming in. And the very senior technician there asked for a mask because he thought that was a sick patient who was coming in. He wanted a mask to be kept ready, an oxygen mask. So this boy brought in the oxygen cylinder because he didn't know that the MRI machine would suck in the cylinder. And along with the cylinder, the technician was sucked in. And this boy also was caught in between the magnet. So it took about 8 hours to release them. And they had several problems, injuries. So, training becomes very crucial on the job and also continuously training them on the problems that are associated.
You said that fear is what stops people to report small errors. because they may either feel very scared that, what will be the outcome of my reporting this, or they might just feel it is too small to be reported, you know. So what are some of the systems that can be put in a hospital for an error to be reported, which may not otherwise get reported by the person or somebody there uh, in that team?
Yeah. So what we look at is multi-pronged reporting, which means, it may be one person. Let's say a medication error that has happened, a wrong medication was administered to the patient. So typically the senior nurses are supposed to be checking on a daily basis, shift basis, what has happened. They're also to counter check, they have to counter check and see which drug has been given. So they will report. Sometimes the patients will tell the doctors, I don't think the right one was given to me or at the right time. So the doctors will report. And what we insist upon is the self-reporting. Because whatever systems you put in place for others to check and report and things like that, unless a person feels confident to report, it's of no use. So several things can be hidden, but it's a multi-pronged approach that we adopt in most hospitals. And we go in for anonymous reporting. We ask them to put down in paper. We ask them to go through the technology enablement through systems that we have put in reporting formats and things like that. But it is all underreported. If I tell you the medication error in my organization is 0.1%, you have to multiply that probably with 100 to say that it is almost 10%, because it is certainly underreported everywhere across the globe. It is not just in our country. Across the globe, this is a problem.
And how important is uh, creating a culture of being an informed patient, or the family of a patient which is informed enough to ensure that they impress upon the people who are going to be taking care, so that those people don't make mistakes?
Absolutely. I think we are coming to the point where patients become stakeholders. So the patient engagement is the key, and WHO has realized the importance of this, and most global bodies have realized the importance of patient engagement. So that's why this year, if you look at the theme of the World Patient Safety Day that happened on September 17th, it was all about engaging with patients as equal partners, trying to understand and getting the feedback. When we talk about feedback, we always talk about patient satisfaction, about the food, whether the temperature was all right, whether the room was clean, whether the toilets were cleaned adequately. No, that's like a hospitality issue that we are talking about. But what is most important is the patient engagement in their care. So it's the empowered patient who can actually make the healthcare delivery safer. So I did allude to the patient-reported experience measures. I want to talk about it a little bit because, that patient-reported experience measures, if they are used as survey tools to understand from the patient actual engagement when he is, let's say, going in for a surgical procedure. If I give a questionnaire to the patient and ask him, were you told about the surgery, the risk benefits involved? Did the doctor take the consent from you? Did the doctors come the previous day and put up the surgical site marking for you? Did somebody receive you in the operating room and did they check your ID band for your hospital number and your name? Did they counter check that you were the right patient? These questions, if I start asking the patient, automatically, if I, as a quality manager, present these reports to the stakeholders, the clinicians and the nurses, and if we notice that the compliance is 70%, 80%, we will then try to make it 100%. We have to show them the mirror, exactly what the patient tells them. So I would certainly say these kind of surveys on patient engagement when it comes to safety measures, particularly those processes that are extremely dangerous, if we are able to do that and give the mirror to our healthcare workers, they will then start engaging with the patients better. And that's the simplest tool, the best tool to prevent mistakes from happening.
Ms. Joseph, I have two questions that stem out of this. One is that, when we compare ourselves to the global healthcare providers, we are a very different environment in India. I
Yeah.
mean, if you look at the number of hours the doctors work, the surgeons operate, it's a stark difference. I mean, you have doctors here who have no time to even go back home and eat food on time or spend time with their family. I mean,
Correct.
they're always under stress. They have almost like 100 patients in their OPD, whereas, I mean, globally we've seen they work 15 days a week, 15 days a month. With so much of pressure, how do you think they would have time to satisfy every patient, inform them? It's like, telling them that, you need to do more work and see less patients. So where are we headed? I mean, how can we really work on the ground, ensuring that safety and quality will be maintained under such pressures?
Exactly. I think it's a brilliant question. And as I told you, it is not the doctor alone. It is the team. The situation that I mentioned, the surgical safety part of it, everything is not done by the doctors. It is all done by different individuals. It could be the nurse who's checking the ID pad. It is probably the anesthetist who's counter checking whether the patient is the right patient who's being wheeled into the theater. So it is designating the right people for the entire process. Now, as I mentioned to you, there are several healthcare workers who are involved in the care of the patient. And if all of them do not align, if somebody makes a mistake, it's that surgeon who will be caught. It may be the nurse who did not check the patient ID bank and a wrong Kumar would be brought in. Instead of the Kumar who goes in for a bypass surgery, the Kumar who was supposed to go in for an angio would be brought inside because there are two Kumars in the ward. So what can one do? Which is why, it's different individuals and it is their responsibility to do that. And if that is not defined and if the doctors are not supported with all these people who are supporting in carrying out the protocol so that these incidents don't happen, then it makes sense. Now, you see 100 patients, 200 patients, and you make 10 mistakes, your practice is gone. So you certainly need to invest in safety to making sure that these protocols are adhered to. How you take help from the others is what is most crucial, which is where the quality management teams really have a large role in making sure that the protocols are written down and the responsibility for each line item of that protocol is also defined. And then it becomes teamwork. Today, it is not one individual doctor. It is a football game. Doctor is only in the front. It is all those people who are behind him, who are supporting him. All of them will have to sing the same song and only then it can become a symphony. So we have to be very, very careful that we are not, in a practice where one individual doctor practices as per what he wants. Today, it is a team game. And unless everybody comes together, all of them have defined roles, it's going to be difficult. And I'm sure safety will be compromised.
And the other aspect is the other side of the other extreme. I remember in 2008 when I was, no, sorry, yeah, 2008 when I set up my first portal, I was very keen to do something that was happening in the US, like rate your doctor, rate the hospital. And midway through, I realized that we are dealing with a very different sentiment in a population that is in India. People are very, very emotional. And if a patient does not get well, even when the doctor could not do anything, especially in the case of terminal cases, they give, a very emotionally strong feedback against the doctor, right? So under this kind of a pressure from the sentiments of an emotionally charged up population that the doctors are dealing with, how do you ensure that the doctor can be stress-free and ensure that he is giving the best that is possible without feeling the fear of getting harmed in the process?
I think it's a very, very difficult thing to answer because, our healthcare system is totally changing. It was only now, I mean, today, it's very difficult to practice as a healthcare professional, as a doctor. I mean, I really pity all of them because the trust factor, the trust deficit has come in. And anything that the doctor does is taken with, whether this was all for the finances, the money, the bill, those kind of things are
Suspicion.
getting, that suspicion is there. So all the more important that the doctor adheres to defined protocols and, has a system in place for everything and communicates properly. Communication is the key. Patient engagement, talking to them is the key. We have seen several cases where mistakes have been committed, but if the patient and the party relatives know exactly what has happened, they are more willing to accept than people who really hide them. So it is important to talk to them and tell them very clearly what is going on in the care on a day-to-day basis. So we cannot hide behind numbers anymore, saying I'm seeing 300 patients, 400 patients. But that critical time, 50 seconds, 60 seconds that you talk to that patient and relative, you have to explain to them very clearly the outcome that is expected. If they don't know that, and if they think this is all going to become all right, and if it doesn't, then it's gone. So it's a very, very difficult game at the moment. And we all know the problems that are in the system. So all the more reason why we have to be focusing on systems and processes to have better outcomes.
And this also, I have a very sensitive question to ask you. And this question is that, since you brought up the issue of the lack of trust, or the first emotion being that of suspicion when you're going to a doctor, especially in the case of recommended surgeries, with the commercial hospitals that have come in, which are typically run by investors, where they're pure play investors, the doctor may be under a lot of pressure to push for something that could be unethical. Now, does that also come under patient safety?
Certainly. It is certainly a
And how do you tackle this?
very, very difficult to tackle, because that's where the ethical dimension comes into the picture. It is so crucial for healthcare professionals to be ethical. And you can correct anything, but if you are not ethical, you just cannot do anything. So the need of the hour is to imbibe that culture of ethical aspects in clinical care. Now, you just cut for the sake of cutting, just operate for the sake of getting those numbers. I think it will be there for a few days, few months, few years. After that, everybody will realize, because patients are also smart. They also know, and today with Google, ChatGPT, and doctor shopping, they will go to 6 or 7 doctors before they take the decision to get themselves operated. So there is trust deficit. That's because there are several unethical practices. We do agree to that. There are unethical practices. But then, that's exactly why we are stressing on ethical practices in the healthcare delivery system. And it's not a profession that it's everywhere. It has become like that now. It is with the lawyers, it is with the media, it is with the politicians. So it's a problem in the nation. I think it is not just the healthcare professionals, but every group has that unethical 15-20% who are spoiling the industry. So
Right.
That's exactly what we need to deal with. And I feel this has to start from the school education. And that's where, the time has come for all of us to start talking about ethics in whatever practice that we do.
I think what could also help is to talk about the culture of safety, culture of quality at the level of the investors who are in the hospital, not just those who are administratively managing the hospital.
Yes.
And link it to the productivity and reputation of the institution.
Absolutely.
Joseph, you and I have been on various conferences. We've been attending a lot of seminars, etc. And there's been a lot of conversation that happens around technology.
Yes.
Now, how is data and technology, especially monitoring, remote monitoring, helping doctors, medical professionals, nurses be more cautious about quality and safety? And is it equipping them? And how are they embracing technology to ensure that they can reduce the number of errors or at least avoid any negligence at their part?
Yeah, I think technology is a force multiplier. So if you have to see a number of patients, you need to have the technology support, certainly. Healthcare is one industry that has embraced technology, that has always been very open in learning, getting the new things in, trying to understand how best we can serve the patients, because we know the numbers are becoming large and we can't be going without technology aids. Let me put it that way. So let me take the example of remote monitoring, because that's something very close to my heart. Now, when patients are monitored, or continuous monitoring, let's put it that way, continuous monitoring of patients. Now, when a cardiac arrest happens in a ward, it becomes a major havoc, because that's something which should not happen. Because if you had monitored the vitals of the patient properly, you could have prevented an arrest in a ward, because the vitals, it will not suddenly crash like that. His BP will drop, saturation will drop, other parameters will drop. So if you have continuous monitoring of that patient, you could have prevented a cardiac arrest in the ward and then resuscitating, taking them to the ICU. Today, you have the technology to continuously monitor your patient. And that gives you the vitals. And if the patient, vitals go down beyond what is desired, immediately alerts come. And you are in a position to immediately intervene. Otherwise, the nurses go every 4 hours, 8 hours, and it's a spot check. It is not continuous monitoring. So what happens, you are able to prevent these kind of incidents. And that actually is a good thing, because these are again patient safety issues. Otherwise, you would have never been able to retrieve that patient, revive that patient, I'm sorry. So if you don't adopt to this, then you are left behind. Now, the problem is with also adopting to it is the expenses that are involved. Ultimately, who's going to pay for all this? It's the patient. Nobody is doing charity. Finally, from somewhere the money has to come. So that's why if you look at it, the more we talk about quality, safety, processes, outcomes, data, monitoring, making sure we are making our system foolproof, it is all expensive. And the healthcare expenses are actually going up. To prevent infection in theaters, we need the best of air conditioning. HEPA filters, laminar flow, positive pressure rooms, continuous monitoring. You can't even switch off the air conditioning. Electricity is expensive. Who gives us the concession for electricity? We have to pay, like an industry. So what happens? It's expensive to prevent that one infection. And therefore, all these go indirectly to the patients. So that's one reason why healthcare is also becoming expensive. But we have to find, draw the balance. If we don't do it also, it's a problem. Because if you have an infection, to treat that, another 15 days of stay is more expensive for the patient. So where do you actually draw the balance? So technology adoption is extremely important. But to what level are you going to go? Today, artificial intelligence, AI, ML, everything is there. But if that cuts down the manpower, if you are able to optimally utilize that and your efficiency and effectiveness is improved, then certainly, yes, you have to jump in. That's my take.
Right. And Ms. Joseph, what is the role of regulations by the government in ensuring and pressurizing the hospitals to give the due importance towards ensuring quality continuously, not just for the sake of accreditation? I mean, because it's like, the private organizations go for the ISO certification, they'll have consultant, counselors, everything, they'll put everything in place. And once it is done, it is just a advertising and marketing publicity board. And then it does not actually fructify to actually doing it. So how do you think that the government regulations could play a role, and what should be done?
Yeah. So the government regulations at the moment, I think till now, we didn't even have a Clinical Establishments Act. Probably only 5 years back, it was actually insisted upon. So I could go and start a Lallu Joseph hospital anywhere, even without a license. But today, with the Clinical Establishments Act, at least, you have to register your hospital. There are basic minimum requirements that are needed to set up a hospital. You can't set up a hospital without an emergency, receiving the patients, making sure that they are given the immediate first aid, stabilized, shifted to other hospital. So there are certain parameters as basic minimum requirements that have come in as part of the Clinical Establishments Act. So that's one. Number two is that all your statutory requirements for fire licenses, building approvals, AERB if you are using radiation emitting devices. There are several licenses that one has to obtain. It's almost like 198 to 200 licenses that one has to obtain. It is too bureaucratic. It's a problem. But at least once you start doing that, you know you're safe. You know you've got the basic minimum standards established. Now, with regards to the quality, government actually has not been insisting on or let's say beyond basic minimum standards. So it's actually the private establishments that are going in for accreditation to fine-tune their systems and processes. Government has a program called the NQAS, the National Quality Assurance Scheme, for the government hospitals. And they've done wonders with the Lakshya programs, Manyata programs for labor room, outcomes, and like the CAHO for basic cleanliness in government setting. At least the basic minimum standards are now getting established in government hospitals. But I feel the private hospitals have gone way beyond that. So because the accreditation standards are n times more than the basic minimum standards. So we monitor everything, whether the outcomes of a bypass surgery, outcomes of a bone marrow transplant that you have done, how many of them have come out properly, how many of them have got the protocol properly followed. So everything is monitored. So government can only do that much. They cannot really have that thing to report everything. That may not be possible. To the maximum, they may ask for some mortalities, some proportional maternal mortality, things like that, what are very crucial for them. But they are really getting there with at least putting some basic minimum standards in place. And that's really appreciable. And especially for government hospitals. See, we keep talking about private hospitals. But what's happening in the government setting is very crucial because 50-60% of the population is going there. And if they are not talking patient safety, it's gone.
Absolutely. And they are the ones under a lot of pressure of time and the number of patients that they serve.
Exactly. And there's no follow-up at all. So at least now they have started something, which is appreciable.
Right. And my last question to you, Ms. Joseph, is that what are some of the performance indicators or metrics that hospitals should monitor to assess the success of whether they are building the culture of safety and quality in their hospital?
Yeah. So what we are expected to do, I mean, there are several literature available on this, and there are several tools to assess the culture of safety in one hospital. One of the best tools that I have seen so far is the AHRQ tool for measuring SOPs, for measuring the culture of safety. So there are several parameters on that, and one of which is incident reporting, and you have questions on the leadership commitment, whether supervisors' commitment to safety. So those are, very simple questions that are put together. And these are validated questions. Of course, this is from the developed world. But contextually, if you ask me, in India, it is very much applicable. That's why people go in for this AHRQ tool. And as quality managers, we actually do this culture of safety survey every year and trying to understand the baseline as to where we stand. And if, let's say, the incident reporting culture is very poor in the organization, we try to take efforts to improve upon it. And if the teamwork is not there, then of course the leader has to take efforts to make sure that the teamwork is established, what's going on in that particular area. So different parameters are assessed. And on a year-to-year basis, you continue to use the same survey instrument to understand where you stand. You can also benchmark yourself with the global counterparts, let's say in the US, in the UK, where do they stand? Or you could benchmark yourself with the Indian data also, if you feed into the global database that is available. So that's a very good tool to assess where you stand. And we from CAHO, we did a very nice study on, and about 150 hospitals participated, about the scores individual hospitals have obtained on these 11 parameters. And we put it all together and we presented that. And that became a benchmarking for India. And therefore, you are able to assess and see as an individual hospital where you stand. The crux of anything is measuring. If you don't measure, you just cannot monitor. So it's important that we continue to measure and see where we stand, even the culture of safety. So there are very good tools available for a hospital to understand where they stand. And I think they have to adopt those.
Absolutely. Ms. Joseph, this has been such a beautiful conversation. I had initially planned it as a 30-minute, but we took a little longer. But I think it was absolutely worth it. I mean, the fact that you spoke about that 1 in 10 people get affected by potentially avoidable harms in a hospital, making healthcare industry a hazardous industry. It is inevitable for us to figure out how we can turn this into a highly reliable industry. And what very clearly emerged was that leaders have the responsibility to set the culture in place. And it is not just the top leader, it has to trickle down at every level. Like you mentioned that, it is the team that is involved. And if the doctor is the head of the team, he has to push that culture that, the protocol is maintained at every point in time for it to reach every person in the team to make that difference. And the other thing that I realized was the importance of making a patient informed through awareness that push for your rights and also for your own responsibilities, that you're the one who should be responsible enough, at least the family that is there taking care of the patient as well. Third was the importance of the monitoring equipment, and we are blessed that the technology is now available, which can help us continuously monitor the patient so that we could prevent, because we are now able to predict what is going to happen to the patient. So that's a very, very important aspect. And there is one suggestion that I have. Just last week, I did a conference in Mumbai where I was talking about the importance of spirituality and the role it plays in living better and being more productive. I think, when you're looking at healthcare professionals, the attitude to imbibe and embrace spiritual mindset will just make them more responsible and feel for the life of the patient so that they could do the right thing. And even probably that could also be the catalyst to invoke that, the ethics, which are now getting compromised, or at least are, allegedly being compromised in the industry. I think, the conversation today has been really, really meaningful. Thank you so much for taking our time, and thank you so much for taking out so much time to discuss this with us.
Thank you. Thank you very much, Harbinder. I really like the last sentence that you quoted. It is all about ethics. It's all about spirituality. And that's exactly the father of healthcare quality, Dr. Avadis Donavidian. He talks about that in a good way. And I thought I will, because you mentioned that, I thought I will just read out what he says. He says, system awareness and system designs are important for healthcare professionals, but they are not enough. They are only enabling mechanisms. It is the ethical dimension of individuals that is essential to a system's success. Ultimately, the secret of quality is love. You have to love your patient. You have to love your profession. You have to love your God. If you have love, you can then work backwards to monitor and improve your system. And that's exactly the thing that we have to work around. It is that ethics, it is that love for that patient, it is that love for that profession, and it is the love for what you do. Thank you so much for having me, and wonderful time I had with you, talking to you. Thank you so much.
Thank you so much, Ravi. Thank you so much. Bye.